It's my pleasure to introduce this morning's speaker, Dr. Paul Cieslak. Dr. Cieslak went to medical school at Ohio State University and then went on to do his residency at the University of Washington. He did an infectious disease fellowship at Washington University in St. Louis and came to Oregon as a CDZ preventive medicine resident in 1994. And since July of 2014, he served as the medical director for Oregon's Public Health Division Communicable Disease and Immunization Program. Dr. Cieslak is going to be speaking to us today about communicable diseases and kind of an update of what's going on in our area in the state of Oregon. Thank you, Dr.
Okay, thank you very much. So this is basically just a potpourri of stuff that's been happening lately. So we're supposed to have objectives for all of these talks, so here's my objectives. State the estimated cost to save 1 year of life by vaccinating all U.S. college students with MenB vaccine. State CDC's estimate of the effectiveness of 1 and 2 doses of mumps vaccine, respectively. State the effectiveness of Tdap, given during pregnancy, in preventing pertussis in infants under 2 months of age. And state how often sexually active men who have sex with men should be tested for syphilis. Okay, so the first set of slides is about meningococcal disease. This curve shows you reported meningococcal disease in Oregon going back basically as far as our current database takes us, which is to 1988. And you can see that our case counts peaked in 1994. That was 136 cases. We were tops in the country with a rate of 4 per 100,000 per year. But since then, rates have declined, and this was well before the onset of, or the introduction of the protein conjugate vaccines that are now recommended universally in adolescents for groups A, C, W, and Y, and certainly before MenB vaccines which were introduced, and I'll get into that in a bit. The blue bars represent serogroup B disease, which were by far the most common, and those of you who have been around a while know that Oregon had a peculiar problem with serogroup B. Most of the rest of the country has typically had about 1/3 of cases due to serogroup B, which wasn't in the earlier versions of the vaccine, but we had about 60 to 65% of our cases were serogroup B. Well, again, well before the vaccine came around, disease rates started to decline, and don't ask us or anybody to explain why. There's really no good understanding or explanation for this. But we hit a historic low in 2013, and last year, 2016, we had just 24 cases reported, 10 of which were serogroup B. And you can see that the preponderance of serogroup B has waned, so that we're now more in line with what the rest of the country is seeing. So for the past 5 complete years, 115 isolates were tested at the State Public Health Lab. I think 38% of those, 42 or 38% of them were serogroup B. So we're pretty close to the 33% that most of the rest of the country typically sees. These are the same data sliced a different way, just looking at all the Januaries together, all the Februaries together, et cetera, so that you can see seasonality. And there's a distinct seasonality to meningococcal disease, with case counts peaking in November through March. And so every year around November, I get a call from the press saying, is it true that meningococcal disease is on the rise? And yes, it's true. It's always on the rise in November. And again, you know, we can speculate as to, you know, proximity of contact indoors during the colder months, but nobody really has a solid explanation as to why this might be the case. Well, some of you are probably aware of the cluster of cases that occurred at the University of Oregon in the early part of 2015. So on January 13th, a 19-year-old woman, student at U of O, fell ill. And then a few weeks later, on January 31st, another 19-year-old student became sick. The day after that, a 19-year-old male student became sick with the disease. And basically, when they occur in such proximity to each other and we can see a connection between the two cases, we consider them co-primary cases, which is important for determining, at least under current criteria, whether or not we should pull the vaccination trigger and say, okay, everybody should get vaccinated. But they're considered as one case. So functionally, at the time of February 1st, we were dealing with just 2 cases. And according to CDC, the trigger was 3 cases before you had mass vaccination. Unfortunately, on the 17th of February, an 18-year-old student died with meningococcal disease. She had a rapidly progressive course, and succumbed within, I think, 24 hours. All of these proved to be serogroup B. Now, remember that up until recently, we only had a vaccine against serogroups A, C, W, and Y, and it was only recently that a serogroup B vaccine was introduced, so that kind of played into some of our decision-making at the time about use of the vaccine. We did pulse field gel electrophoretic typing, sort of a DNA fingerprinting on the isolates, and they were all identical, so no surprise there. When a new strain hits a population that hasn't had it before, it can spread a lot, and these were all highly related strains. The bottom bullet shows you the antigen properties of the strains, the serogroup B strains that were isolated. So it had factor H binding protein number B24, nicerial heparin binding antigen peptide 5, and no nicerial adhesin A. So it turns out that just before this cluster of cases occurred, a couple of vaccines, or actually the second vaccine was licensed during the cluster. So Trumenbo was the first one licensed on the 29th of October 2014, and it's a 3-dose vaccine series to be given at 0, 2, and 6 months. They've since been able to get an FDA label to make it 0, 1, and 6. Or alternatively 0 and 6 if there's no urgency in getting the antibody levels high. But at the time it was 0, 2, and 6. And this vaccine is basically only factor H binding protein. So that's the only thing in the vaccine is factor H binding protein, which comes in several different flavors across meningococcal strains, but virtually all meningococci have factor H binding protein. There are 2 major subfamilies of this binding protein, subfamilies A and B. Turns out about 2/3 of the cases are subfamily B. But they put one of each, they put a representative protein from subfamily A and another one from subfamily B into their vaccine. Then in January, as I said, sort of between cases in our cluster, Bexsero was approved by FDA for, it's a 2-dose series for use at 0 and 1 month of age. And this has actually got 4 different proteins in it: nicerial heparin binding antigen, nicerial adhesin A, factor H binding protein, and the porin proteins that are found in the outer membrane vesicles on the bacterium. So both of them come in 1/2 ml prefilled syringes for intramuscular injection, and they're both labeled by FDA for use in persons 10 to 25 years of age. It turns out that the Advisory Committee on Immunization Practices did not put an upper limit on vaccination, although the studies were only done in persons up to 25 years of age. But we think it would probably be effective in older people as well. We're not so sure about whether it would work in kids. So these are some of the immunogenicity data on which the Trumenba vaccine was licensed. Now, you should appreciate that case rates are now so low that it's almost impossible to do an efficacy study for the drug companies. At 24 cases last year, that's basically 6 per 100,000 per year of all serotypes in Oregon. And at 10 of those cases were serogroup B. So in Oregon, in all of 2016, your risk of getting meningococcal serogroup B disease was 1 in 400,000. There's 4 million people in the state of Oregon. There were 10 cases, so about 1 every 400,000 cases. So think of the numbers that would have to be vaccinated, with the vaccine and with a placebo in order to get statistical significance on use of the vaccine. In any case, the first 4 columns here, A22, 56, B24, and B44, show different factor H binding protein subtypes, and what percentage of them had at least a 4-fold rise in serum bactericidal antibody titers 6 months after the vaccine was given. So remember, this was a 3-dose series. They did not provide any data on how many have responded to a single dose, but after 2 doses, you can see the numbers here, and there's quite a bit of variability between the different antigens. And after the 3rd dose, you're seeing responses in 81 to 95% of people based on the type of antigen that it is. And then they came up with this composite index, which is the last column, which is just what percentage of subjects had any detectable serum bactericidal antibody response to all 4 of the antigens. So that's what they called their composite response. I highlighted B24 in orange because that's the strain that primarily has been circulated in Oregon with our serogroup B strain. Now, this is the other vaccine, the Bexsero, and a couple of things to pull out of this slide. So again, they're testing everybody at 6 months, at 0 months and then at 6 months of age, after giving them the vaccine on the schedule that you see on the right, either a single dose at time 0, or 2 doses at time 0 and 1, or 2 doses at time 0 and 2, or 3 doses at 0, 1, and 2 months. And a couple of things to pull out of here are that, you know, after a single dose, your response is in the 73 to 76% range, depending on which antigen you're testing. And then with another dose, a second dose at 0 and 1 or 0 and 2 months, you get up into the 90%. And it doesn't seem to matter too much whether you give that dose at 1 month or at 2 months afterwards. So they ended up getting a label for 2 doses at 0 month and 1 month. And then if you look at the ones who got 3 doses at 0, 1, and 2 months, yeah, they're all maybe a little bit better, but not a lot. And so that's why FDA said, okay, you can have a label with just a 2-dose series instead of a 3-dose series. So we recommended vaccination of all undergraduate students, as well as grad students who lived in on-campus housing and fraternity and sorority members in the wake of these first 4 cases. And the university undertook a mass vaccination campaign and contracted for Trumenba, the 3-dose series, to be given. So, you know, I don't know what went into all the contract negotiations, but that's what they came up with. Now, one of the complications of this was that we did not have an ACIP recommendation. The Affordable Care Act requires first dollar coverage of vaccines recommended by the Advisory Committee on Immunization Practices. So one of the complications was they hadn't spoken yet before we had to make the decision about vaccination. So, you know, we're working with insurers and everything to try to get them to agree to cover the cost of the vaccine, and most of them came around pretty quickly. But it wasn't until the end of February that ACIP actually voted. And they did not vote for a universal recommendation in adolescents, as was the vote several years before for the quadrivalent conjugate vaccine, ACW and Y. Rather, they voted that people in these specific high-risk groups should be vaccinated. People with functional or anatomic asplenia, people with terminal complement component deficiency, and this, you know, they're known to be at very, very high risk of meningococcal disease. This eculizumab was a new one on me, Soliris. I guess it's a monoclonal antibody used in paroxysmal nocturnal hemoglobinuria, and I think maybe one other condition. But it binds to C5, and so it functionally renders you deficient in the 5th complement component. And then microbiologists who are routinely exposed to isolates of Neisseria meningitidis. And then finally, and here's where we come in control of serogroup B outbreaks. And so we see this as giving us a certain amount of leeway in determining, you know, whether there's an outbreak or not, and determining who's at risk because of that outbreak. So what did they say about adolescents? Well, they said all serogroup B a serogroup B vaccine series, so they're not expressing a preference between either of the 2 formulations, may be administered to adolescents and young adults 16 through 23 years of age to provide short-term protection against most strains of serogroup B meningococcal disease. The preferred age for Men-B vaccinations is 16 through 18 years of age. And they gave it this is a so-called Category B recommendation. So Category A is, you know, all members of this group should get it. So it's fairly definitive, you know, so everybody should get a dose of Tdap. That would be a Category A recommendation. But this is, it may be administered, and so this is what they call a Category B recommendation, and the implication is that the physician should have a discussion about risk factors and such, and do some individual patient-by-patient weighing of risks versus benefits. And so that's the recommendation that they made. When we wrote our standing orders under which all local health departments vaccinate their patients and under which pharmacists in Oregon, it turns out, vaccinate their patients. We did not authorize routine universal vaccination of adolescents with serogroup B meningococcal disease. And my rationale was, well, you'll see some of the expense rationale, but part of the rationale is the disease is really rare. You got to vaccinate hundreds of thousands of people to prevent a case, and the vaccine is so new that, you know, who can be sure that the risk of a serious side effect from the vaccine exceeds the benefit to be provided against a rare disease? Here's CDC's interim recommendations on use of the vaccine to control outbreaks in organizational settings. So this doesn't apply to, you know, we had 3 cases in the city of Portland. That's not an organization. So they limit it to when you can draw a circle around people, you know, by dint of their association with some organization. So count only primary cases of infection, as I mentioned earlier. That's why those 2 cases were sort of considered a single case. The decision to vaccinate should consider whether the strain is covered by the vaccine. So we had a serogroup B, and we knew that the antigen type was one that should be covered by the vaccine. And consider vaccination. So again, they stopped short of saying you should do it. They're given, I think, local public health some discretionary leeway here. When in a population under 5,000, when you have at least 2 cases within 6 months, and with a population over 5,000, at least 3 cases within 6 months. So this is, you know, as you can imagine, you know, pretty crude and arbitrary, but they're trying to draw some lines and help people out when they come into these sort of rare situations, and that's what they came up with. I will say that I'm on a work group with ACIP where we're considering revising these guidelines, and I see some changes coming, but this is what we had then and what we have now. They also state that the risk in these organizations is back to baseline 1 year after the last case. And I'll show you, again, we're dealing with small numbers of scenarios here, but I'll show you where that comes from. The University of Oregon held mass vaccination clinics with this 3-dose series, first in March of 2015, and then 2 months later, at time 2 months, in May, and then at time 6 months in October. And they continued to vaccinate new freshmen coming in until the end of the year. The total case count for the outbreak was 7 cases, 6 of them in undergraduate students and 1 in a visitor to the campus. The last case having occurred in May of 2015. And so, you know, taking their risk is back to baseline after 1 year, we basically said, okay, May of 2015, you know, we'll call it over at the end of spring quarter 2016. And so we consider that outbreak to be over. So no more cases after May, but there were a couple of cases after the vaccination campaign commenced, but probably before very many people had a couple of doses in them. I want to say about half of the students, U of O estimated, I think about half of the undergraduate students got the first dose of vaccine, and then the numbers are going to go down from there. So it's not like the whole campus got vaccinated. Okay, so this shows you 10 different, or maybe it's 9, different university clusters that CDC has data on, and they were trying to figure out, well, when can you declare an outbreak over? So each of the clusters are shown on the x-axis with the number of days between cases shown up on the y-axis. And the largest time between cases, I think, was this outbreak number 3 here. And there were about 250 days between those 2 cases. So something over 8 months and less than 9 months. And that was the longest that anybody went and then still had another case after the outbreak. And so that's kind of where we get the, well, if we draw the line at a year, we're probably safe. So a little bit of epidemiologic analysis of the cases that happened at U of O. So remember, we're talking about 6 cases in students. 4 of them were freshmen. The other 2 were sophomores. So it definitely appears to be the younger students, which kind of makes some epidemiologic sense. But there were 3,780 freshmen on campus, according to their register, and 4 of them became cases for a rate of 10.6 per 10,000. Whereas 2 cases in the rest of the undergraduate population of 15,470, or 1.3 per 10,000. So freshmen were 8.2 times as likely to fall ill as non-freshmen. What about dorm residents? So only two of the 6 occurred in dormitory residents, but there's only 3,505 dormitory residents. So their risk was higher, 5.7, compared to those who lived off campus at 2.5. Not statistically significant, but there you have it. The Greek affiliation, I think, was striking. So 4 of the 6 cases were members of fraternities or sororities. Not necessarily living in the house, but they were members of the fraternity or the sorority. And I can tell you that one of the other 2 that wasn't frequented the fraternity and sorority events, and so had a lot of contact with those people. But if you just limit yourself to those who are actual members, you've got 4 out of 3,159. They were 10.2 times as likely to get sick as non-Greek members. And this kind of all dovetails with what we think we know about transmission of meningococcal disease. It's spread by respiratory droplets. It's in the saliva. So anything that, you take a bunch of people from all over the state and maybe even all over the country, and you put them together in one spot, and you have them living at close quarters, and maybe there's activities going on that affect the exchange of saliva, like sharing cups or utensils or or kissing or bongs or beer pong. I kept hearing about, and pretty soon they're trading bacteria and viruses, and whatever somebody's got, now everybody is exposed to, and so it kind of all fits with what we think we know. Well, if you've been paying attention, you're aware that there are now some cases just recently at Oregon State University. So the first case fell ill in an undergraduate student in mid-November. It proved to be serogroup B. 3 days later, there was a second case. So we're kind of, we're off to the races again. Now, around each case of meningococcal disease, we know that close contacts, usually defined as household members and best friends and people who spend a lot of face-to-face time together, such that you might have some respiratory droplet transmission. But not everybody. Often when a case comes into the emergency department, it freaks people out, and everybody thinks they need prophylaxis. And we're usually kind of like, hold your horses. The respiratory therapist who was doing the suctioning, the nurse who attended the person, maybe a doctor or 2, but it's not sort of everybody in the emergency room. It's not spread by the airborne route such that you're coughing it into the air and it's staying suspended. You need some close contact. So what we do is we give antibiotics, usually ciprofloxacin or rifampin, to household members and other close contacts. The thinking being and the data being that you'll eliminate the carriage from the nose and throat before it has a chance to invade and cause invasive disease. Oh, and one interesting thing I want to mention is the U of O cases, none of them had meningitis. All of them had meningococcemia, which was really curious. But so we give prophylaxis. And at the U of O, at the OSU situation now, we said, let's do a really liberal antibiotic prophylaxis. I mean, instead of just doing the roommates, let's do, the whole floor, or basically anybody who comes in and says, I think I was exposed to the person. So we were also reasoning that it's going to take a couple of months for immunity from any vaccine that we give to kick in. And with 2 cases occurring 3 days apart, we're most concerned about that intense transmission in proximity to the cases. So we undertook kind of several hundred people in each case were prophylaxed. CDC whole genome sequencing came to us 9 days later, kind of a remarkable turnaround time, in my opinion. And the isolates were identical to each other, and they clustered with the University of Oregon strains. They weren't totally identical, but they were very, very close. So they could tell that these were Oregon strains and that they could separate the U of O from the OSU strain. And we held our breath and we were doing well until mid-February, when there was a 3rd case and it proved to be serogroup B right away, and we said, it's probably going to be wishful thinking to hope that that it's not a molecular match, and so we decided to to recommend vaccination of OSU undergrads. And CDC whole genome sequencing came in sometime later, and sure enough, it's identical to the other 2 strains. So on March 8th and 9th, OSU held its first vaccination clinic at a field house, whose name escapes me, on campus. So we recommended vaccination of all OSU undergraduates 25 years of age and younger, whether they lived on campus or not. But we said, you know, let's try to target especially, you know, the areas that we think are at higher risk, the congregate living settings like fraternities and or even people who visit the fraternities or, and the dormitories. So we recommended this kind of targeted vaccine, but we are recommending the vaccine for all OSU undergrads 25 years of age and under. Spring break is almost upon us, so I guess this week would be finals week. And one of the things I want you all to know is, you know, if OSU undergrads are coming to you, you know, the vaccine uptake was not great at the vaccination clinic, and I suspect that a lot of parents are going to be flogging their kids over the break to go in and get a vaccine. So if you have the opportunity to see one of these kids, please vaccinate them. The university is using Bexsero this time, the 2-dose series. And it's important to know which one is which because they're different antigens. They're not the same vaccine. So it's not like if you get, you know, Trumenba and then get a dose of Bexsero, you boosted the Trumenba. They're totally unrelated. So you got to stick with one vaccine, look them up in the immunization registry, and give them a vaccine. Similarly, you know, if you see somebody from OSU who's looking you know, ill, I mean, just have a low threshold for considering meningococcal disease or meningococcemia in such patients, you know, until the outbreak's over anyway. So that's one of their posters. Now, I wanted to go into some of this cost-effectiveness data because I get a lot of questions, and there's a lot of people whose, you know, initial reaction is, well, why don't we just vaccinate all the college students? We're seeing these clusters in universities and everything. And I think the answer is twofold. It's number one, even so, the disease remains rare. It's easy to say after the fact that, you know, these people were at risk and you should have vaccinated them. But before the fact, the disease remains rare even in college students. And so you're vaccinating a lot of people with a vaccine for which there's still no effectiveness data and which is expensive to prevent a very rare disease. So CDC did this cost-effectiveness analysis. If you vaccinated all kids at 11 years of age in the United States, you'd prevent 15 cases and 2 deaths. So you'd have to vaccinate 203,000 people to prevent a case and 1.5 million people to prevent a death. And then they come up with this cost per quality adjusted life year saved. So I usually just abbreviate it as life year saved, but you do get some credit for preventing morbidity, and that's included in the quality calculation. But if you just think of it as to save a healthy year of life, it's $8.7 million to save 1 year of someone's life, okay, on average, right? Now, obviously, you know, if you're saving someone from dying at age 11, you're saving a lot of years of life lost, but that's all factored into it. So to save each year, you're paying $8.7 million. If you vaccinate everybody at 16 years of age, you prevent more cases, 28, 5 deaths, and at $4.1 million per life year saved. If you vaccinate everybody at 18 years of age, similar figure, I guess that's the sweet spot, $3.7 million per quality adjusted life year saved, and the most cases prevented. And if you vaccinated all college students in the United States, you'd prevent 9 cases and 1 death at a cost of $9.4 million per year of life saved. So this is one of the reasons why I'm not excited about pushing universities to vaccinate all their college students. And the bottom, you know, the way to think about it is this is an expensive vaccine as vaccines go. It's about $320 for either the 2-dose or the 3-dose series. The manufacturers price them pretty similarly. And it's directed against a disease that has gotten pretty uncommon, even in the absence of the vaccine. Because I was curious about where do you prevent the most cases, and they're figuring that immunity is going to wane after 3 to 5 years. But this is incidence of disease in Oregon over the years, all serogroups, by single year of age. And you can see that, you know, infants are at higher risk, and there's another rise in incidence among the elderly. But during adolescence, there's this little peak, which is what you'd be trying to prevent with an adolescent immunization campaign. And the peak year is at 18. And so, you know, if you really want to prevent the most cases with a vaccine whose duration is expected to be 3 to 5 years, you would vaccinate somewhere around that time period. You know, here, based on Oregon data, if you didn't consider the national data, you might put it at 15 years of age, but ACIP says 16 to 18 is what they came up with. Because incidence, you remember the cost per quality was higher if you vaccinated at age 11, and the reason is that the incidence rises through adolescence, peaking around age 18, and then it starts to fall off. And why shouldn't we vaccinate the older people on campus? Well, by the time you get to this age, your disease rates are pretty low. Okay, switching gears now to pertussis. Boy, okay, I hope I have time to get through all this. Incubation period of 7 to 10 days. It's an upper respiratory infection. It has minimal fever. You start with a catarrhal stage, a head cold that lasts a week or two, and then you go into the paroxysms of cough, which I've got 1 to 6 weeks here, but some people have dubbed it the 100-day cough, convalescence weeks to months. The DTaP vaccine, which is given, you know, to children at 2, 4, 6 months, boy, this is wrong. It's at 2 months to 6 years of age. 2, 4, 6 months, and then another dose at 15 to 18 months, and then another dose in preschool, is about 80% effective initially. So, you know, don't poo-poo the value of the vaccine. It does work very well, but you know, like meningococcal disease and as we'll see mumps, the immunity does wane after a few years, and so you're going to see cases after several years. The Tdap vaccine was licensed in 2005. This is the one that is given at 11 to 64 years of age, and a single dose is recommended in all adolescents and adults. So everybody should have had 1 dose of Tdap vaccine. And the rationale for not giving boosters repeatedly is that the titers, they just don't last very long, and so at some point you reach diminishing returns. So a single dose. This shows you pertussis by year in Oregon. We had very low levels of disease down in the 1970s and early 1980s. And we have some data that suggests that correlating with the rise in disease that we saw afterwards, and some of this has to be due to better diagnostics. PCR, which is now used almost universally, is 3 times as sensitive as culture anyway. Margaret's nodding her head, thank you. And so some of it is just increased diagnosis, but we think some of it's real as well. And we've looked at our data, and during that 1997 to 99 period is when we transitioned kids for their priming series from the old DTP, the whole cell pertussis vaccine, to the DTAP, the acellular pertussis vaccine. And there's, and we think the data are pretty good that the titers are likely to wane and you don't boost as well if you've been primed with the acellular vaccine as opposed to the whole cell vaccine. Why do we use it? Because the whole cell vaccine had a lot of side effects, a lot of screaming kids, and an occasional case of encephalitis. And so I don't think we're going back, but we do have this problem to deal with of waning immunity. Because we have pretty good data in our immunization registry, we were able to look at incidence of pertussis among vaccinated kids and unvaccinated kids, basically at every different stage of vaccination. So the 2 to 3 months old, they're supposed to have 1 dose, right? So you're fully vaccinated if you've had 1 dose at that age, or you could have had 0. And you can see that if you've had the 1 dose, or if you haven't had the 1 dose, you are 54 times as likely to get sick, to get pertussis, as the people who had the 1 dose. Similarly, at 4 and 5 months, you're supposed to have had 2 doses. And again, on and on down the line, you can see that at virtually every age group, at every age group, you're more likely to get sick if you haven't been vaccinated than if you have been vaccinated. And starting at 11 years of age, we considered you fully vaccinated if you had your 1 dose of Tdap ever. Then you're fully vaccinated, and you can see that you're still better off with the vaccine than without it. I want to look at pertussis among infants because we've decided that that's where we really need to focus. So all of these data are from infant cases, less than 12 months of age. And I'm showing you incidence in cases per 100,000 by how many months of age they are. And you can see that the disease incidence is peaking at 1 and 2 months of age. And then another problem on top of it is that those are the kids who, when they get it, are most likely to be hospitalized by it. So kind of a double whammy going on in that less than 2 months of age group. Whoops. These are data just showing that they're much more likely to be hospitalized. And remember, you don't get your first DTaP vaccine until 2 months of age. So that first vaccine isn't even really coming on until you're past the highest risk period. You're still at substantial risk during the rest of infancy, but the ones who suffer the most are the ones who are too young to have received that first dose of vaccine. Well, I'm going to kind of blow through some of these things too on recent history of Tdap. But the important thing is that in in October 2012, the ACIP recommended Tdap vaccine for women during each pregnancy. And the rationale is that mom will mount an immune response, an antibody response, and those antibodies are passed not just passively across the placenta, but actively. The antibody titers will be higher in cord blood than they are in maternal serum. So during the 3rd trimester, there's this active push of antibody across the placenta. So you want to vaccinate them, preferably at the beginning of their 3rd trimester so that they can mount the response and then have several weeks to push the antibody across. And the nice thing is we now have data that shows that this works. At the time, it was sort of more theoretical. But this is an observational study in England, and they have, Public Health England has very good immunization registry data. So they looked at all the babies born between October 1st, 2012 and August 31st, 2015, who developed pertussis within less than 93 days at the onset of their pertussis, so less than 3 months of age, basically. They looked at all the PCR or culture confirmed cases. They excluded cases whose mothers were vaccinated within 7 days of birth. Presumably they didn't, you weren't sure whether they were going to have an meaningful immune response at that time, and cases vaccinated after birth. And they got their background immunization rates for all these kids from their registry. And so the effectiveness of vaccinating mom during pregnancy at preventing infant pertussis at less than 3 months of age was 2 months and 3 months. I think I might have reversed that because, yeah, this first one I think should be 2 months because an odds ratio of 0.09 means you're 0.09 times as likely to get sick if you're vaccinated or the vaccine is 91% effective. So at less than 2 months of age, 91%, at less than 3 months of age, 90% effective. And you're at much higher risk if mom hasn't been. So we're really trying to push this notion of maternal vaccination during each pregnancy. ACIP looked at how many pregnancies women are likely to undergo. I think something like 2/3 of women have 3 or fewer. And then, very small percentages have more than that. I think you're on the order of, no, I'm sorry. I think you're down under 10% by the time you get to 4 kids nowadays. And so, it's not like they're getting vaccinated with a dozen doses of vaccine anymore. Okay, mumps. We've had mumps lately. Mumps is a paramyxovirus, like the measles virus. Its incubation period is 16 to 18 with a range of 12 to 25 days, which is how long we keep people out of school, for example, if they have it. It's communicable in saliva from 7 days before to 14 days after the onset of parotitis. Can be asymptomatic. There's a prodrome of low-grade fever, anorexia, malaise, headache, and parotitis in 30 to 40% that lasts up to 10 days. We talk about other salivary glands being affected, and of course, even other glands. I mean, the pancreas can be affected, testes, ovaries, but when other salivary glands are affected, it's usually with parotitis and not in their absence. So complications. In the pre-vaccine era, orchitis was reported in up to 50% of post-pubescent males, but sterility was rare. There are some data suggesting that an episode of orchitis is associated with testicular cancer down the road. Oophoritis in 5% of postpubescent females. Up to 15% get aseptic meningitis. It was one of the more common causes of aseptic meningitis in the pre-vaccine era. Spontaneous abortion in 25% of women infected in the first trimester. Deafness in 1 of 20,000, and assorted other occasional complications. So an inactivated vaccine was developed back in 1948, but the vaccine we currently use is a live attenuated vaccine, the so-called Gerald Lynn strain. If you'll read our most recent CD summary, you can read an account that we report from Dr. Paul Offit about Dr. Hillman, Maurice Hillman, developing this vaccine when his daughter fell ill, and he hurried up and swabbed her and isolated the virus and passaged it serially and attenuated it and et cetera. It was licensed back in 1967 and was in routine use by 1977. So a single dose of mumps vaccine is about 78% effective in preventing mumps, according to CDC, and 2 doses about 88% effective. Now, although ACIP recommends 2 doses for students in K through 12 nowadays, our school law doesn't require it. It requires 1 dose. However, our school law does require 2 doses of measles vaccine. And virtually all measles vaccine is now given as MMR. So practically speaking, if the kid is not, choosing an exemption to vaccination, then they're going to have 2 doses of mumps vaccine anyway. And here's reported mumps in the United States, along with some vaccination milestones: the 1977 first dose recommendation, the 1989 2-dose MMR recommendation, which was instituted because of the big measles outbreak in 1989 to 91. And here you see uptake of 1-dose and 2-dose vaccine series, and cases went away accordingly. But then starting in 2006, we started to see some big outbreaks. So this one was centered in several universities, most notably, I think, in Iowa. And we had some cases back then as well. And then occasional clusters since then. And last year, there was a large outbreak in Arkansas, a couple of thousand cases centered around Marshallese communities, Pacific Islander communities who weren't opposed to vaccination, but I think a lot of them were, not hooked up to our medical care system, and so a lot of them were unvaccinated. This shows the Oregon data for mumps, and in 1981 we had 69 cases, and then for some reason that I'm not aware of, they stopped making it reportable. And so it wasn't reportable again until 2006, when in the face of all the cases nationally, we reinstituted mumps reporting. And we haven't had many cases, a handful, until October of last year. So this shows cases reported as of February 25th nationally, and you can see that there's still a lot of activity around this part of the country, Arkansas, Missouri, which is, I think, just sort of leftover transmission from last year. Washington State is a little behind in reporting to CDC, but I think they've got about 400 cases already so far this year. One point that I wanted to make with this slide is that although you saw rates of orchitis, the previous slide said up to 50% of orchitis in unvaccinated postpubescent males. In the vaccine era, most of these complications appear to be much less frequent. Arkansas, I think with its 2,000 cases, was reporting like a couple of cases of aseptic meningitis maybe, and very little orchitis as well. So even if the vaccine isn't preventing all the mumps disease, it's probably still effective in preventing some of the more severe consequences of it. So here are the Oregon data going back to 2006 when we reinstituted reporting. And during 2016 to 2017, and again, most of the cases in 2016 were since October, I think we're at 51 cases right now. So it's here, it's around. And I think the trajectory of mumps, well, I think what's going on is that immunity from the vaccine is waning. So if you got your 2 doses of MMR vaccine, typically you get dose 1 at 12 to 15 months of age, and you get dose 2 in preschool, 4 to 6 years of age. Now you're good to go for school. Well, by the time you hit, you know, high school or college, by the time you hit college, for example, where some of these outbreaks were clustered, it's been 14 years since you had a dose of the vaccine. And so if immunity wanes, and there are some outbreak investigations that show that it does, then you know, they're kind of reaching that point where they no longer have immunity, and once again, you're bringing in lots of people at close quarters, and so they're more likely to get whatever's being passed around. And so you see these clusters in colleges. In Oregon, we had a cluster in wrestlers, primarily high school, but also middle school wrestlers, and people who were wrestling with big cheeks. And you know, we saw transmission from some of those wrestling tournaments. There was also a big national tournament in Minnesota, and a lot of cases spread out from there. So that's what I think explains the picture. I think where we're going with mumps is we're gonna, you know, see a chronic state of endemicity of mumps, that it's just gonna go on and dwindle along with a case here and a case there forever. I think we're, you know, not imagining that we're going to be eradicating this with the current vaccine. And currently, we're not recommending a 3rd dose of mumps vaccine. Most of the cases we've seen have been pretty mild, and we're sort of unwilling based on that to pull the trigger and say everybody should get a 3rd dose of vaccine. Okay, syphilis. Oh boy. Rates of early syphilis by sex, you can see that our case count, I mean, we thought we were on the verge of eliminating syphilis back in 2000, and CDC announced a campaign. Well, that was the kiss of death. And so now case counts are way up. In Oregon, it's overwhelmingly in men, although there is a rise, as you'll see in that yellow line, in women in recent years as well. And of the male cases, more than 90% are in men who have sex with men. So this is probably an effect of rejection of condom use. A lot of MSM are telling us that they don't want anything to do with it, and they want to do barebacking, and you know, HIV is treatable nowadays. They're not afraid of it, and maybe there's probably not that much HIV transmission going on if they're on highly active antiretroviral therapy, but that leaves them susceptible to syphilis. One of the disturbing things is the specter of congenital syphilis. So recently there was a 22-year-old woman from Eastern Oregon with suspected history of meth use who came in, presented in the late 3rd trimester to an urgent care center far from her home, it turns out, with fever and chills. A baby boy was delivered elsewhere a week later and then discharged. You know, they didn't have the history of mom's fever and chills before this. And at 2 months, the baby was admitted for fever and failure to thrive. A week after admission, an reactive RPR was collected from the mother that had been collected from the mother prior to delivery was recognized. And so part of the problem in recognition was the distance between these 2 events, the mother's admission and the baby's birth. And congenital syphilis was diagnosed in the infant. So one of the things we're tracking is early syphilis in women, and you can see that it's been going up and up. You know, so almost 60 cases, I think that was in 2016. And along with that is some congenital syphilis. So 6 cases in 2015 and 2016, and 1 already in 2017. CDC, I guess, is now, or people who talk syphilis, and I'm not one of them, are now distinguishing between what they're calling morbid syphilis and, I don't know, not so morbid syphilis. So some of them are sort of just positive lab results that, you know, we're worried about and we need to be treated. And the morbid syphilis are the ones, you know, with sort of the classic congenital syphilis. So CDC and the American College of Obstetrics and Gynecologists are recommending more screening prenatally. In communities and populations in which the risk for congenital syphilis is high, serologic testing and a sexual history also should be obtained at 28 weeks gestation and at delivery. So once upon a time it was once during pregnancy, and now it's at 28 weeks and at delivery as well. And then test the following at least annually and every 3 months if they're sexually active with multiple partners. MSM with a history of syphilis or other STIs, or HIV-positive men, or heroin or methamphetamine use, every 3 months. So those are the current recommendations. MSM should be screened for syphilis every 3 months. And again, if they're sexually active, you know, a lot of them are meeting up with partners anonymously using various internet services, and that's where we're seeing the vast majority of our syphilis. So if we hope to get on top of this again, we're going to need a lot of screening and treatment and maybe some behavioral change. We ask that you ask the patients to name their partners and give you contact information if they can. Unfortunately, a lot of them will tell you, I don't know who the partner was. And so we have a SIP Aware campaign going on. I'm going to try to wrap this up. Let's see. If not for syphilis, we have rising rates of gonorrhea. So the gonorrhea incidence has tripled since 2010, with risk factors being men who have sex with men, methamphetamine use, HIV is correlated, and previous STI is also correlated. Fortunately, the good news is that there's no sign of decreasing cephalosporin susceptibility in Oregon. So, you know, some parts of the country, they're moving away from, you know, the initial recommendation of shoot them with ceftriaxone. But in Oregon, it still works, so that would still be our recommended therapy. A couple slides on Zika. This is, you know, so Zika is not being transmitted within the state of Oregon, but we are seeing plenty of people who are arriving from the Caribbean in particular who have had Zika. So I think we are at, there's 582 tests, and I think we're at something like 47 cases of Zika reported in Oregon so far. The blue boxes at the bottom show you the confirmed cases, and the orange boxes show you the presumptive. Presumptive means they had a positive IgM titer for Zika, but because of cross-reactivity with other flaviviruses like dengue and chikungunya, we're not able to say definitively that it was Zika. They didn't get the follow-up test, obviously, at CDC to try to confirm that it was Zika. But you know, we're seeing it with some regularity now. Pregnant women who have visited the areas where Zika is being transmitted, or who have sexual contact with a man who has visited one of those areas, are also recommended to be tested. And we've tested more of them than we have of symptomatic people. But a smaller percentage of them are positive. But because we're worried about the congenital Zika syndrome, we want to be more aggressive about testing pregnant women. Oh, and we did have one sexually acquired case in the state of Oregon. So you can look on our website or CDC's website to see the testing algorithm, but basically we want to test symptomatic people who within a couple of weeks have been to one of these areas, or pregnant women, whether she's symptomatic or not. And the testing, if you get the patient within 14 days, get urine and serum. The urine test is probably better than, well, it's better than an antibody test because they can PCR the virus out pretty reliably out to 14 days. So we would like you to get both urine and serum. The first test they'll do is a PCR on the urine, and if it's negative, then we'll test the serum for IgM. At 14 days, though, you're much less likely to find the virus in the urine, and so just get an IgM. Just get serum for IgM testing. And then any IgM that's positive, we will reflex to CDC for this plaque reduction neutralization test, which is able to distinguish better between the various flaviviruses. Okay. So, objectives. State the estimated cost to save 1 year of life by vaccinating all U.S. college students with MenB vaccine. $9.4 million. State CDC's estimate of the effectiveness of 1 and 2 doses of mumps vaccine. 78% and 88%. State the effectiveness of Tdap giving during pregnancy in preventing pertussis in infants under 2 months of age, about 91%, according to the England study. State how often sexually active men should be tested for syphilis. Right, every 3 months. Okay. Thank you for your attention. Sure.
What are your comments about parents who refuse vaccination?
Comments about parents who refuse vaccination? You know, we wish they wouldn't. The legislature has taken some steps to try to minimize the number of people who take so-called religious exemptions for reasons of convenience by making them get a sign-off from their physician that he's given them education or watching our online module. So we're trying to reduce it. Right now in Oregon, it's around 6% of kindergartners are exempting from one or more vaccinations based on non-medical reasons. You know, this population is very difficult to convince. I think by and large they've told themselves that people like me have drunk the Kool-Aid and are not a reliable, you know, we're sort of brainwashed by CDC and whatnot. And we have not had a lot of success with coming them around to our point of view. I see one of my roles as being to counsel the doubtful. So the ones who are kind of wavering and saying, geez, I've got a lot of friends, I've heard some things, you know, and tell them, you know, those things aren't true. Vaccines are actually quite safe. You know, tens, hundreds of millions of doses have been given, and you're doing the right thing by vaccinating your kid.
What does Seventh-day Adventists do with it?
What?
What does Seventh-day Adventists to do with it? How did they come in?
Seventh-day Adventists? I don't know that they're all opposed to vaccination, so I don't know where Seventh-day, I don't know whether there's a religious proscription against vaccinations. Ron.
That was a great presentation, thank you. Questions about the syphilis. You mentioned the non-morbid syphilis diagnosis, and as a clinician, I get a lot of questions because of the way we've reversed the syphilis testing to now do treponemal antibodies first. We get a lot of results where there's a patient who doesn't have any symptoms. They got screened and they have antibody, but they don't have an RPR positivity, and they don't have a history of treatment or syphilis. And so any sense of what percentage, are those cases that are counted in the state numbers or national numbers for syphilis, or is that a subset that gets taken out and we don't really quite understand what's happening with those people?
Yeah, the question has to do with what do you do with patients who are getting this so-called reverse syphilis screening, first with the fluorescent treponemal antibody and follow-up, a negative follow-up, RPR, right, a negative RPR follow-up. I have to plead a certain amount of ignorance on these. I think part of the answer has to do with, has the patient been reported with syphilis before? And but I'm not up to date on the latest case definitions. I'm sorry, I'm not in the HIV STD section. I was presenting some of Sean's stuff because I thought it was most interesting to clinicians, but I'm not totally familiar with it. Sorry.
I didn't quite follow the thing about adult Tdap, and then why you don't 10 years later give them another. Can you just run that out for me? Because if you're giving it once and it's helpful, why isn't it helpful to do it again 10 years later?
Yeah, so why only one adult Tdap? You know, you do mount an immune response to Tdap, but the serologic data suggests that it wanes in a year or two, and your risk of actually coming down with pertussis in that year or two are not sufficient to recommend boosters. So why do we do it even once, right? I guess that's a good question. I don't have a good answer for you. Why is that? I haven't given a lot of thought. Right. So tetanus boosters, and there's some question about whether those are needed so frequently as well. Yeah, I'm sorry. The current recommendation is one dose of Tdap, and I don't know why you would need that one if you don't need the rest of them. Obviously, we want the moms to get vaccinated during pregnancy, and we kind of feel like it'd be a good idea for family members of infants to be vaccinated if they haven't been. But repeated doses of Tdap are thought to be, you know, it's too much to prevent too little. Yes?
What is the reason for the pertussis in Washington State? Also wrestling, or?
You mean the mumps in Washington State?
Yes, the mumps, yes. It's amazing that Oregon is relatively mildly affected, and Washington is more than 40 cases or so.
Yes, I don't. The question is why why there's more mumps in Washington State. You know, we've had roughly 50 cases since October, and Washington State has had several hundred. I don't pretend to know the answer to that question. I can tell you that I think they're seeing it in the same sorts of groups that we're seeing it in, you know, middle school, high school, college-age kids, but I don't have a good reason for why they're seeing more than we are. Dr. Kravitz.
Hi, Paul. I was curious, the 3 cases at Oregon State that have happened in the last few months, were they related to one another or dormitory?
Were the 3 cases of meningococcal disease at Oregon State University related to one another? No. They did not have known connections between each other. They are what we would call 3 primary cases. And the fact that we can't relate them to each other means the cat is out of the bag. You know, the bacterium is spreading through the campus population in ways that we don't know, and that's a big part of the rationale for a mass vaccination campaign. Yeah.
And since these students probably have interactions within the community, how do you assess what your denominator of the case attack rate actually is, since they live in the community, not just perhaps in a dormitory? How do you figure that out?
How do we assess the population from which these cases are arising? You know, our methods are crude at best because we don't have a good way of sort of saying, you know, here's all the social networks and here are the relevant ones to which they belong. And so, you know, we crudely say among Oregon undergraduates or among freshmen and sophomores or things like that, you know, something that we can find a reasonable denominator for. But we haven't, you know, they're not all dormitory residents. Some of them live off campus. We're not finding the fraternity sorority connection. The only thing, the closest thing that puts them together is their Oregon State University undergrads. That's it. One more question.
Do we have any evidence of Zika mosquitoes in this area? Part 1. Part 2, what's the prevalence of polio and smallpox in the world?
Okay, first question was, do we have Zika mosquitoes? No. Zika is only known to be transmitted by Aedes aegypti and Aedes albopictus. We have lots of different Aedes species within the state of Oregon, but we do not have albopictus or aegypti. So currently, we do not anticipate mosquito transmission of Zika within the state of Oregon. The second question is, what's the state of smallpox and polio? Smallpox has been eradicated from the world. The last case was, I think, 1980. And that was a laboratory-acquired case, and the last naturally acquired case was like 1977, I think. So there is no more smallpox in the world. Polio is now, thankfully, reduced to just 3 countries, Nigeria, Pakistan, and Afghanistan. And those are all in places where conflicts have made it difficult to get vaccination campaigns going. So in Nigeria, it's the Boko Haram areas. And in Pakistan and Afghanistan, it's Taliban-held areas. And, but, you know, substantial progress has been made. I mean, wiping polio out of India was a major public health achievement. So we really are down to a few dwindling number of cases. And, you know, I would hope that within a few years we can be done with polio as well. Thank you all for your time.